Hey everyone, this is Joe Minardi. I'm coming to you live from the West Virginia University recording studios. And today what I'd like to do is go over a few kind of principles and then get into even some specifics about point-of-care ultrasound-guided regional anesthesia. Frequently when I talk about this subject, I like to ask the audience, how many of you think we should prescribe more opioids in our general practice or daily lives? And, most of us think fewer opioids would be a better thing in the care of our patients. So that's why one of the many reasons to talk more about regional anesthesia. So I'm going to go through a couple of cases that just kind of illustrate some of these things that we might do or some of these things where regional anesthesia might help us. So this first example here, this is a young patient who crashed their bicycle. They've got right shoulder pain. You might see something doesn't look right with his shoulder here. This next patient is an IV drug user who's got a lot of swelling and pain here. This looks like something that, maybe needs some intervention. They've got a fever. This patient's got something going on with their hand, looks maybe infectious. They've also got, a lot of pain. They've got a lot of fever. This, maybe you're going to need to do something with this. This is an 82-year-old female who just had a simple fall from standing and has a lot of hip pain, is now unable to walk. This is a young gentleman who had a motorcycle crash, is in, pretty significant pain, pretty significant distress, probably maybe going to have to be transferred out of the facility where you are and going to have some delayed time towards definitive care and surgical management. This next one, just someone who kind of missed a step walking down to the basement in their house, and this is the injury that you see, and they're having a lot of pain. Here's another patient who's got just pain in their foot, got a lesion here, it looks kind of red, swollen, and this patient also has a fever. So we've got all these patients, they've got these kind of infectious looking things, they've got these injuries, obviously leading the witness here, but what are some of the options? Well, we could do, depending on what's going on, we might be able to do some kind of a local anesthetic injection. Sometimes that may be perfectly appropriate and reasonable and work well. For some of these things, procedural sedation might be the route to go or what we might be thinking about. Opioids, obviously, they've been a mainstay for decades, if not nearly a century. And then there are other agents we can use. You can talk about pain dose ketamine, some of the anti-dopaminergic drugs like Haldol, or even some of the second generation things like Zyprexa, things like that. This is something we all kind of think about, talk about, you've heard about. Hopefully some of us are already incorporating some of this into our practice, but what I'm going to talk about here with regional anesthesia is part of a kind of a more multimodal approach to pain management instead of just kind of slamming people with tons and tons of fentanyl or morphine or Dilaudid or whatever else you might have at your disposal. And obviously today this is where we're going to focus. And so I'm just going to show you, here's a kind of quick overview that kind of demonstrates this is one specific procedure, but the overall technique is similar across different anatomical subsections. So what we see here in this case, we've identified the nerve. Here it's the sciatic nerve near the popliteal fossa, and we've brought the needle down. We're injecting. We're going to try to surround this nerve with local anesthetic in hopes of encouraging a nice, complete, and full nerve block for whatever this patient's got wrong. So there's the nerve there. We're trying to surround it with local anesthetic. Sometimes we may be identifying a nerve itself and trying to inject all around it. And other times we might be identifying a fascial plane and trying to fill up that fascial plane with local anesthetic. But we'll get more into those details as we go on. Here are the objectives more for the CME purposes. I won't read these to you, but they're there for your reference, and these are available. Here are some of the quick take-home points, and obviously we're going to get pretty detailed into the weeds here, but point-of-care ultrasound guided regional anesthesia is good. That's as simple as I can state it. I see this in my practice. There's good literature for this, and this is a way we can help patients. We can decrease reliance on opioids, maybe not eliminate completely, but we can decrease the need for it. It's very important to understand the contraindications and the complications that may occur. Even though we're using ultrasound, we're doing things to minimize these things, there are still things that can go wrong. And probably the most important thing is guiding your needle is the fundamental skill. If you are good at guiding a needle, then you can learn or kind of refresh yourself on some anatomical landmarks and findings and kind of adapt that to any of these procedures. And so that's why when some of our other things we've talked about, guiding a needle is the most important thing. If you're very skilled at ultrasound guided peripheral IV insertion, then you probably can do this fine, especially if you can do an in-plane technique. So that's a very important skill. Beyond that, if you can know the anatomy, we'll go through some of the anatomy, but if you can guide a needle, you can refresh yourself on the anatomy pretty quickly and then find the approach that's going to fit the situation you're in, just to emphasize that even further. And again, just want to point out, there is nothing, if you've got a body part that hurts, there's not much more that's going to be more effective than a good nerve block or regional anesthesia. Depending on the scenario and the injury or the pattern of the process, regional anesthesia may not be complete. It may not make complete insensate area of injury or concern, but it's going to decrease the need for other analgesic modalities. And in some scenarios, you may be able to take their pain to come from like 50 to 0 right away. There's a significant literature base for many of these things that we're going to talk about. Here's just one talking about doing regional anesthesia for hip fractures, randomized control trial. This is another one about doing regional anesthesia and geriatric hip fractures. Here's one for the fascia iliaca compartment block, which we're going to talk about in hip fracture patients. And there's even a nice Cochrane review talking about peripheral nerve blocks for hip fractures, talking about earlier mobility, decreased delirium, decreased opioid use, in some cases even shorter hospital stays. So there's a pretty good literature base on most of these. And this is kind of the overarching theme of what the literature says, is that there's high quality evidence showing that regional blockade reduces pain on movement within 30 minutes, and moderate quality evidence showing lower risk for pneumonia, decreased time to mobilization, decreased cost of the analgesic regimen overall. And this was single shot blocks in the emergency department. And so kind of, again, my kind of little take homes about this: earlier and wider use of ultrasound guided regional anesthesia, pain relief, lower opioids, which are probably the number one thing, lower complications, lower use of resources, often even getting patients out of the hospital faster, getting them on their feet faster, just a wide range of benefits by implementing this early on. Now, complications, we have to talk about a few of the things you have to think about, because even though, again, we're using ultrasound to guide what we're doing, things can go wrong. We have to be aware of these and know how to deal with them if we identify them. The general ones that can happen with kind of pretty much any nerve block, or any time you're invading the skin: infection, vascular injury. If you're close to a nerve injury could be a potential complication. Depending on where you are, if you're doing something in the brachial plexus, a pneumothorax might be a consideration, and maybe it just fails. That's another thing, that maybe it's nothing drastic bad that happens, but it doesn't work, and then you have to do other modalities to treat their pain or treat their symptoms. These are all very low. The incidence of any of these things are pretty low, but they still exist. They're not zero, and so we have to be aware of them, and we have to use strategies to mitigate some of these risks. So all these complications are reduced because we're using ultrasound guidance. But they are not zero, and you can't neglect them, and they have to be part of your informed consent process. So just before we get into specific blocks, a few general considerations. We have to think about what patient are we selecting, and then selecting the proper target for the injury or the patient's disease process. Once we've decided what's the best target, we have to figure out how we're going to identify that target. Then we have to do the right prep. Part of the prep includes being prepared for any complications that could occur. And then we'll talk a little bit about the approach to the specific nerve block or the anatomical component, as well as the procedure and post-procedural care. So a few notes about selecting the patient properly. One thing that's important about any patient where you're going to do regional anesthesia or a nerve block is they need to be awake, alert, and they need to be able to participate. So they need to be able to tell you if they're getting paresthesias so that you can stop your procedure or kind of back up your needle or change your approach. So you can't do this on obtunded or completely out of it patients who are unable to participate. They need to be able to give informed consent. Obviously, they should not have an allergy to the agent you're using. You should not be going through an infected site. And that's sometimes one of the advantages if you have, like one of the examples we showed of the forearm where there's an infection. Well, the site for our nerve block is very proximal to that, well away from that infected area. So that can be an advantage to using regional anesthesia over local injection. Compartment syndrome. So this is something that comes up. Compartment syndrome in itself, or concern for compartment syndrome, is not a complete contraindication, but you need to be aware of the risk of compartment syndrome, or maybe masking symptoms of compartment syndrome, and have a plan to mitigate or monitor that patient carefully so that you don't kind of cover up or make it difficult to diagnose a compartment syndrome. Some might say it's a complete contraindication. That's not the case, assuming you have a plan and a discussion with other providers who may be involved in the patient's care. So target selection, this is important because sometimes the place where we place the block and the territory that block is going to cover is not always 100% intuitive. So if you're not sure, or if you're doing a block that maybe is a little bit newer to you, it's always good to just check a reference and make sure that the block you want to do is going to cover the area you want to cover and anesthetize that area. And it's always worth considering how easily you're going to be able to approach or do the injection, some of the relative risks. And you want to do the most distal block you can do that's going to be effective, because the more distal your block, the lower risk it is for other significant injuries or complications. If you need to do a proximal block, you need to do it, but if you can do a more distal block that will still give you a similar or equivalent effect, then the distal block is always preferred if possible. Other pieces of prep, patients need to be on a monitor. If you're doing a forearm block or something down around the ankle, maybe this isn't quite necessary, where it's going to be a very low volume of local anesthetic. But anything, a general rule of thumb is the knees up and the elbows up. Anything proximal to the knees or proximal to the elbows, where it's going to generally be a higher volume block, this patient needs to be on a cardiac monitor and pulse oximetry monitor during and after the procedure. Part of the reason is we need to be aware of and be monitoring for local anesthetic systemic toxicity. We need to be aware of what volumes we're giving, the potency of the agents we're using. We certainly want to avoid intravascular injection, and we want to know the signs, symptoms, and how to treat local anesthetic systemic toxicity. So this is why we have them on cardiovascular monitoring, so we can look for PVCs. And another one, this may be a little bit further down the line, is they may develop nystagmus. Sometimes they might just say they feel dizzy or funny. So these are things to look out for and be aware of. And if they get these things, you certainly, if you're still injecting and some of this happens, you certainly want to stop the injection. Most likely this is going to happen after you've finished the injection, and you want to be ready to treat this. And we'll talk about the treatment here in just a second. One of the things about using ultrasound to guide this is that it helps us with better targeting, and we're able to use lower volumes. In the past, when you used maybe landmarks, which is pretty much almost nobody's doing landmarks anymore, you would just get close to a landmark and just inject a whole bunch of anesthetic, hoping it's going to diffuse around your nerve or into your fascial plane of interest. But with ultrasound, we can pretty much target the needle and try to get it exactly where we want it, and hopefully use lower volumes. So this can decrease the risk, but the risk is still present. So you need to be aware of it, need to know the signs to look for, and be ready to treat it. And this is the treatment. So the treatment is just intralipid. And for those who recently maybe rotated or did an ICU rotation, or maybe working, or the ICU is the place they live, this is the TPN substrate, only without all the other additives. So the initial treatment is 20% intralipid, 1.5 to 2 mLs per kilogram bolus, and then you want to start a drip at 0.25 mLs per kilogram per minute. The initial bolus is probably worth committing to memory, and then you can look up the drip rate. But you need to have this reasonably available to you if you're going to be doing any regional anesthesia, again, proximal to the elbows or proximal to the knees. A little bit about equipment. For most of these nerve blocks, we're going to go ahead and recommend you do a full sterile prep, sterile gloves, prep the area. For the most part, a sterile prep is reasonable. For handling the probe, you want to do just like you would do a central line, do a nice sterile prep, sterile setup, put a sleeve over the probe, sterile gloves, and everything like that. For the most part, especially again, proximal to the elbow, proximal to the knees, we're going to use spinal needles for most of these. If it's something in the brachial plexus or one of the blocks for the lower extremity at the knee or above, then I typically, what I use is a 20 gauge spinal needle, and I will look at the target beforehand and try to figure out the shortest needle I can use. The shorter the needle, the easier it is to manipulate, but it has to be long enough to get to the target. So the shorter the better. 20 gauge is kind of my rough go-to. In most emergency departments, a 20 gauge 3.5 inch spinal needle is pretty easy to come by. A few things about ergonomics. If you've looked at some of my other procedural materials, we talk about getting everything lined up, get the screen and the target in your field of vision, get things to an appropriate height. You want to make manipulating the needle kind of easy, driving it away from your body. So this is some of the prep we talk about. Get yourself stabilized, get nice height, get things in front of you. Now this is something I talk about sometimes with kind of all ultrasound guided procedures. You want to be this direction, perpendicular, where the needle is going away from your body. You have a little bit better stability, a little bit better control, and your accuracy is improved when you're driving the needle away from your body versus this kind of sideways thing where the needle is crossing in front of your body as you go. This less control, less success, a little bit harder to do versus driving the needle away from you. So this is what you want to do. This is not what you want to do. So before you even start, set your ergonomics up and set your positioning up so that you can be driving the needle away from you. Here's just a quick review of Inplane needle guidance technique. Now this is vascular access, but the needle technique applies across the board. So now we're going to do a long axis target Inplane technique. So with this technique, I'm going to orient the indicator away from me. My needle should come in from the right side of the screen. Now in this technique, we get our target locked in place and we never want to move that transducer again. And this time our needle goes directly underneath the transducer with almost no space. We just barely try to get in the skin, and then we do side-to-side movement until we can visualize it, and then we do side-to-side movement until we can visualize it, and then we do side-to-side movement until we can visualize it, and then we do side-to-side movement until we can visualize it. And then only when we can visualize the tip of the needle do we advance. And then only when we can visualize the tip of the needle do we advance. And then only when we can visualize the tip of the needle do we advance. So every millimeter or two that we advance, we confirm by side-to-side movement before we finally advance into our target. And remember, if we're sliding an angiocath off, we need to get right in the center of the vessel so we have room to get our angiocath off. Or at this point, we could thread a wire for a Seldinger technique as well.